Welcome, everybody. This isn't quite Respiratory Care Week, but it is next week, so a preliminary Happy Respiratory Care Week. I'm going to stop my video here because you don't need to look at me. We're going to look at the slide. So my first lecture for today and tomorrow is Applying Science to Deliver Evidence-Based Respiratory Care. Here are my disclosures. I'm the consultant speaker for Monahan Medical Corporation and a manager of Kaufman Consulting. What I do a lot of is a lot of volunteer work for the AARC, and you have that listed here. Second disclosure is we made a decision when actually Terry and Al talked with me, and I'm providing the honoraria that I get from this to these charitable organizations. And as they say, food and clothes for the body, hope for the soul. So I hope you participate in your own way in the method that you can do so. Our foundation for applying the science of what we do is based in protocols. So what do protocols have been shown to do? Here's some examples. Assure quality, align resources, meaning your labor and the services that you provide, improve patient satisfaction, reduce cost, eliminate waste. I'm going to talk about this a little bit later, and improve RT staff satisfaction. That last one may be new to you, but I'll show you a published citation in respiratory care that shows how implementing protocols improved staff satisfaction. I bet every week, if not more frequently, I get an email or through the AARC or a phone call, Gary, I need a protocol. Do you have one? I have hundreds of them, but easier than that, and if you email me, I'll send you whatever I have. But easier than that, just go to aarc.org and type in the search bar protocols, and you'll get this and this and this and this and a whole bunch more. I just stopped copying and pasting. Protocols are the science of respiratory care. Now, what is a protocol? It's a respiratory care plan that is designed and developed with input from physicians and other key stakeholders. It's approved by the organization's Med Exec Committee and administrative leadership. Now think about that. Is it the only way to provide care? No, it's a guideline, it's a plan. It's not just designed by respiratory therapists. It's designed by respiratory therapists in conjunction with medical leadership, perhaps your hospital attorney, compliance officer, pharmacy, nursing, anyone who would have involvement. It's important that we consider that in our submission to have a protocol approved. Now the question is, I would ask, okay, we have protocols. Why do we need them? To address misallocation of respiratory care. And here's one I'm going to just stop on just for a second. Care given, but it's not needed. Care needed, but not given. So in some cases, we're providing procedures, performing procedures that aren't clinically indicated. Other times, we're not providing something to a patient who needs it. So how do we do that? It's assess and treat or evaluation, whatever you want to call it. Secondly, improve the quality of care. And it's the right care at the right time, at the right place, at the right quality by the right provider, and that's a respiratory therapist. What other outcomes have been shown? Decreased length of stay. And you may be thinking, well, if I use a protocol, how does that decrease the time the patient spends in the hospital? And I'll give you some examples of that. Improve outcomes. What we do more often than not, in fact, far too often, is your value as a respiratory therapist, mine as when I was a practicing clinician, may be measured in how many procedures you get done, an 8-hour shift or a 12-hour shift. How many vent checks? I'm going to talk about that. I do not like that term. It's patient ventilator assessment. The device checks itself through the EMR. Counting things that we do is important because the administrative directors, the directors or managers of department heads of your departments, they are held accountable for counting things. But let's be clear, counting things that can be counted but don't count don't matter. So if you're doing incentive spirometry, Q1 hour while awake, there's no evidence for that. Bland mist therapy through an aerosol mask, stacking, using acetylcysteine to decrease sputum consistency. None of those have been clinically validated. So we need to align our time, our value with improved outcomes. Cut costs. Does anyone listen to this not heard from their boss or administrator? We need to reduce costs. Absolutely. One way to do that, in my opinion, the only way to do that is to eliminate procedures that don't need to be done and utilize that time in another area where you can provide value. Example I gave working with an RT director is she had approximately 2 FTEs that were consumed by doing incentive spirometry. And what I recommended to her was helping her as a friend. And I said, I would not cut these positions. I would cut them and paste. Stop doing incentive spirometry. In her case, she agreed, her medical director agreed. Take those 2 positions and start pulmonary rehab program. So when you hear the word cut, at least for me, cut and paste. How could we better utilize our time? Improve RT satisfaction and demonstrate our value as not as a tech, not as a doer of things, not a task completer, but rather aligning our time with outcomes. Now, this is from a publication way back in 1993. And the reason I use this is that, in fact, I took a picture of this with a regular film camera before I had a digital camera. That's why it may be a little fuzzy. I want it to be a little fuzzy where those people say, well, we don't have protocols. You know, they haven't been around. They haven't been validated. 1993 is not even the first study. If you look above, it goes back to 1986. And in my career, in the early 1980s, where folks started to look at, is this procedure that was ordered clinically validated? And look at this list. I won't go through each of the numbers. Oxygen administration, 38% of the orders were clinically inappropriate. Might be too high, too low. In some cases, the individual didn't need oxygen at all. They just got 2 liters by cannula because they came in through the ED, and guess what? That's what you get in ED. Bronchial hygiene, this would be CPT, bronchodilators, etc. 61% in this study done by Dr. Shapiro, well known, were not necessary, were inappropriate. Blood gases, aerosols, oxygen. Look at these different studies. Every single one says that it's not clinically appropriate. Excuse me a second while I get my mouse out of the way. Now, what's a protocol impact? Here's another publication, this slide has a number of citations. Protocol-based respiratory care. I like the term patient-focused respiratory care protocols. It's a mouthful, it's hard to say. A lot easier just to say protocols. But for me, and I started saying this probably 8-10 years ago, putting the patient first. That's the object, that's the goal, that's the outcome, improving their care, reducing their length of stay, improving their oxygen level, improve their ability to cough. Patient-focused respiratory care protocols. I'd really ask you to think about that. If you use the phrase RT-driven protocol, that many of us did and many of us still do, yes, you're managing the protocol, but what's the object? The patient. So look at these, and we'll go through each one, but 1996, 1986, 1989, anywhere from, what's the lowest here? Here's from 48% utilization to 11% in the heart study done in 1989. That's a reduction of waste. Therapies that weren't needed, some not needed at all, some maybe didn't need the frequency that they had. So the example I give is, patient comes in the hospital, COPD patient, Mr. Brown comes in and he needs to be admitted because he's had a horrible exacerbation of his COPD. Would a Q4 albuterol order be reasonable? I would think so. So we start the therapy. Physician orders it. We start the therapy. And Mr. Brown goes home Friday afternoon at 11 o'clock. If we're still giving Q4 bronchodilators, albuterol in this case, have we done what we should for the patient? And my observation, my experience, my reading of articles and text and listening to others, the answer is no. Because Mr. Brown's going home and he's not going to get Q4-albuterol at home. He should be on a maintenance medication if indicated. So what happened? Let's back it up to Wednesday. Let's back it up to Tuesday. Let's start over on Monday. Q4-albuterol. Sounds like a good treatment. You give it, you come back and you give another one. And then you start to say, boy, he's really improved. Maybe I should back this off to Q6. So by Wednesday, maybe Mr. Brown's on BID and PRN. And Thursday and Friday, you're teaching Mr. Brown how to use his LABA ICS, his maintenance medication, not just giving him a rescue medication. So I think when we think about this, protocols are guidelines, putting the patient first and saying, this is what the individual needs. No more, no less. Let's use the science. This is an interesting study published, I guess 30 years ago now. Geez, when I look at the date. And what they tested physicians, nurses, and therapists and said, do you, as a physician, a nurse, a therapist, do you know how to correctly take an MDI? And the numbers aren't good. Physicians, 43 to 65%. There was a range, different types of physicians, self-administered it correctly. Nurses, 4 to 83%. Therapists, 85.5 to 100%. Not sure why we didn't hit 100% there. So when people say, can anyone teach the patient to do an MDI, DPI, SMI, whatever, or a nebulizer? The answer is the best educated and competency tested professional to deliver respiratory care services is an RT. We're not a doc. We don't have a depth and breadth of knowledge. We're not a nurse. We don't have their depth and breadth of knowledge. But in the world of airways and alveoli and sputum and cough effectiveness, we're it. We're the ones that need to be explaining to the patient, and I'll suggest patient and family, maybe other caregivers, how to correctly use that MDI. And just a parenthetical comment here. A study was done, a quality assurance performance improvement study was done looking at the percent of patients who were ordered for an MDI that the order included a valve holding chamber. And the outcome was not good. It was hardly any. We know that if a patient's going to get the particles in that 2 to 5 micron range, and the vast majority in their lungs, not in the back of their throat, you need to use a valve holding chamber. So 0% of those orders in this short period of study, about 3 months, 0 of those orders for an MDI also had an order for a valve holding chamber. Who could be the individual, the professional that educates the physician to that? RT, we're the ones. The other aspect of this is valve holding chambers. And I actually ask you to call some pharmacies in your area or talk to your social workers. What do these different devices cost? They could be $10 for rescue medication. It could be $200 out of pocket for the maintenance medications. If an individual is going to spend that kind of money, they need to be able to use the device, or we've not done our best for them. Now, if you're talking to someone in finance, they don't understand MMAD, they don't understand sputum, they don't want to hear the word sputum. They're looking at revenue and expense, and for the most part, it's expense. So here are 5 studies dating back, what's the oldest we have here, 1988, that show when patient-focused respiratory care protocols are utilized, a lot of money is saved. $150,000, Rick Ford did the study in 1994 out on the West Coast. Haney in 1993, $4,000, heart, $206 per patient. So if you think about that, you have, let's say, 200 COPD patients in your protocol. 200 times 206, that's a lot of savings for the organization. And what does that demonstrate to your executive team? Respiratory therapists have the knowledge, have the skills, are competency tested. And not only do we provide great care, we provide great care and save money. That's the words that are going to resonate with the finance individuals, because that's their sweet spot, is finance and budget. What can we do to help the organization while we're helping patients get great care? Utilize patient-focused respiratory care protocols. So here are the challenges. In no particular order, there are those physicians who don't want to order protocols, don't want to hit that assess and treat button in your EMR. Why is that? I'm not going to give you the answer, but I'm going to ask the question. Talk with them. If you're not utilizing protocols today, and there's a physician, hopefully not your medical director, but if there's a physician who says, I just don't believe in it, show them the science, show them the citations, show them your patient assessment tool that your department has. And if you don't have that, email me and I'll send you a bunch of them, or you can just Google it. And they may not trust you because they've not seen your critical thinking skills. That needs to be front forward. Secondly, some of us just don't have the training to do this. Maybe we were taught in school, hopefully we're all taught in school how to implement protocols. But since we haven't done it for 10 years, I don't remember how. That can be overcome. The third one, in my experience, is usually one or two reasons. Is I'm concerned protocols reduced waste, reduced the number of treatments, maybe I won't have a job. And what we have to look in the mirror and agree is, if we're doing the right thing, the procedure, the service, in the right way, at the right time, following evidence-based practice, we're going to have a position, a better valued position in the organization. And it may mean that we take a therapist time, a couple thousand hours a year, out of med-surg care and put that person in an RT navigator role, or create those hours to create an RT navigator role, or pulmonary rehab, or a prehab therapist to help reduce post-op pulmonary complications. The fourth is misuse, and protocols are guidelines. They're based upon the best available information. What we've got to look at is how they're utilized and link protocols to an outcome. If you start a patient mobility program, a ventilated patient mobility program, and you don't expect the patient to fall without injury, might add, it's important that you have that discussion with risk management, compliance, nursing, physicians, and others. If you're not mobilizing patients today with a transport ventilator with a nurse and therapist walking them up and down the hallway, you're going to have falls. You're just going to have falls. It's going to happen. What you want to make sure is that you gently bring that person back to Mother Earth without an injury. So think about adverse outcomes. If someone said, well, we've been doing this ventilated patient mobility program for 90 days, and we've had 3 falls. We never had falls before. Well, guess why? The patient wasn't out of bed. You can't fall if you don't leave the bed. What we need to understand and have this discussion with risk management and other stakeholders, there are going to be falls. The evidence shows that there will be falls. What we need to do is make sure the patient is gently allowed to hit terra firma. Inconsistent RT adherence. And this is a process metric or measure that I look at, is it's important to make sure we, the respiratory therapists, are following the protocol. Take a little check sheet. I can do it right now. Hear me, I'm holding up a 8.5 by 11 piece of paper. It said, here are the 10 things I need to do and document. We need to make sure that we, as the therapist, are following the protocol, because the worst thing that could happen, and I mean for our patients, is we have a protocol based upon evidence, but we don't follow it. And not following it does not give us positive outcomes. If you're reporting to a quality committee and 6 months after implementing protocols, they say, well, we've had outcomes, but they're not positive. We need to make sure that we've been following the protocol, because maybe the outcomes are because we're inconsistent in following our protocol. Next to last, protocol is not based on best available science. I'll talk a little bit more about science in some slides coming up, but basically, protocols are not dogma, are not precise are not the only way to do something. It's the best available evidence that we have, and I'll talk about this more. We don't always, in fact, we rarely base our procedures at the N of 1 randomized controlled trial, or RCT, abbreviated level, for reasons I'll explain later, pardon me. It is that season in North Carolina. I am taking my maintenance medication, my rescue medication, and still going to cough, and I apologize for that. It just is the season. The last one, and this is something that I help directors with in particular, a lot of the services we provide we don't get credit in the productivity system, and that can be changed and should be changed by utilizing the AARC's Safe and Effective Staffing Guide. Not a commercial, not a plug, I'm not marketing the resource. It is the standard by which we can accurately determine how many respiratory therapists we need for a given patient demand, a number of services required. And if it means we don't get a check mark for something, but it's the right thing to do, we need to have that discussion with the folks that manage and look at our productivity. Now, here's some recommendations. These are just a list from my personal experience, and I'm here to tell you I've had as many failures as successes. Some days I think far more failures than successes. Learning from others, listening to folks speak, such as you have today and tomorrow with A&T Lectures, going to AARC events or my state society annual conferences. This is my list. Do your research. The very first thing before you talk to anybody, hit the books. I've been saying hit the books for 40 years because that's how long I've been a respiratory therapist. Actually, a few more than that, if I'm counting correctly. Hit PubMed, hit CINAHL, hit all of the online tools and resources that you can very easily pull this up. If you work in a hospital, back in the day, you go down to the library and ask the librarian, hey, can you dig up some articles on protocols for ventilator, what we used to call weaning, now we more properly call it ventilator liberation. And the librarian would call you, you had a stack. Now, if you work in a hospital or organization that has that, it may even be on your desktop. You click on it, type in protocols for ventilator liberation, and you're just going to get an almost endless list. It's important to read them, make sure they're valid research. Second, and I'd almost put this in a tie with first, if your RT medical director isn't on board, stop. There's no point trying to go further. If your medical director doesn't believe in the value of patient-focused respiratory care protocols, stop your work and engage your medical director. There's no reason that this individual shouldn't support, but you don't want to be talking to med exec committee and have your medical director say, I don't support it. That's just the end of the discussion. Engage all key stakeholders. So who might they be? Nurses, hospitalists, intensivists, family practice, pulmonologists certainly, administration, risk management, finance, budget. Yes, make a list. All those individuals that could support protocols and would help you to not provide the care certainly, but would help measure. So that individual in finance and budget who's looking at your productivity, it's important when you put another, let's say 30 minutes in for a patient assessment, that individual recognizes that's part of the protocol. You have to get what I call credit for that 30 minutes. It's not that we're not providing care. We're looking at the chart, we're assessing the patient, we're creating the respiratory care plan, and on what I would consider a daily basis, updating that care plan based upon the patient's response and if they're getting better or sicker. I think from my personal experience and having talked with literally hundreds of therapists, start small, pick a unit. And pick a unit that you know you can manage. I remember back in the day, I worked at a hospital in Pennsylvania, and we had one unit that had, I think it was 28 rooms, half of them semi-privates, by the way, that's that long ago, that had individuals with cardiorespiratory conditions. That's a great unit to start. Don't pick 6 other units where there's a respiratory patient here, there's 2 there, there's 3 there. Pick, if you can, ideally, a unit and do a pilot program. Base your protocols on the AARC clinical practice guidelines and other national standards, ATS, ACCP, and others. Now, just a quick note. I was giving a similar lecture just a few weeks ago, and the person said, hey, where are the CPGs? I can't find them. They're old, they're moldy. Well, the AARC has released 2. They're working on 2 currently that they will be released shortly, and then they're going to be working on a 3rd one. Clinical practice guidelines are absolutely the foundation on which we build our protocols and our care. In fact, the AARC created a new position in the executive office for a leader to lead the clinical practice guidelines. Linda Goodfellow is her name. And just stay tuned. And if you're an AARC member, hopefully all you are, go to AARC.org, click in CPGs or clinical practice guidelines, and you will see what we've had historically and a bunch of new ones coming up. Select procedures on volume and impact. If you have 1 ventilated patient every month in your organization, if you work at maybe a critical access hospital, I wouldn't start with ventilator liberation. I would start with bronchopulmonary hygiene. Make sure that we educate, and competency test the clinical therapist before we launch. And my recommendation is, it's the middle of October, week before RC week. And if I were going to launch a patient-focused respiratory care protocol, I'd be thinking January, February. And why is that 3 or 4 months out? Is do it right. Get the research, engage the stakeholders, educate your clinical staff, and do some pilots. So let's say we have a more senior therapist taking a more junior therapist out, assess the patient, and then come back and talk about it. And that's a checkoff that actually could be used for your competency checkoff for your department and hospital as well. But educate, test. The last is PDSA, or some use PDCA, is once we do something, we need to make sure that we go back and monitor it and tweak it as is necessary. In this text by Dean Hess, Dr. McIntyre, and a couple other folks, Bill Galvin and Shelley Mishu, there's a chapter on science, on statistics. And the question I would ask of you, and I think it's a rhetorical one, how many people tuned in to hear Gary Kaufman talk about statistics and p-values and interquartile ranges? You didn't, and I don't want to hear it. The experts have done it for us. I'm just going to take a couple minutes and talk about this. This is important. This list is actually a table in Dean Hess's chapter. And I looked at that, I thought, I need to understand what each of these things mean. What's the definition? And when I read an article or I talk to a sales rep, it said, hey, I got this new gizmo. It's better than what you got. And here's the clinical evidence of it. Well, if it's 9 patients who did it and got better, but it was just 9 patients and they didn't test it against another group, that really is not systematic. Single observational study. You go into a patient's room, you give them a breathing treatment, and how do you assess the patient? Respiratory rate, their breath sounds, their ability to cough, their ability to clear secretions, perhaps their pulse oximetry reading, and any of your other assessments. So you give a breathing treatment and you assess the patient before and after, and they get better. That's a single observational study. Does it mean that you delivered an intervention that improved the patient care? Absolutely. The patient got better because of what we just talked about. Does that mean you can go to the next patient, do the same procedure, and get the same results? And the answer is no. There are standards outside the hospital. I always use CAFE standards for cars. When you go to a dealership, there is by law, at least on new cars, a sticker that says how many miles per gallon they get. That is a standard. It does not mean that SUV gets the same mileage as a compact car. It might be 14 miles per gallon and 30 miles per gallon. But you know the science on measuring that efficiency is standard. So when we look at a single observational study, the only thing that we can draw from that is it worked for that patient. Let's do it again. Now to go back to frequency, that patient's on Q4 with a bronchodilator. You do that breathing treatment and they get remarkably better. What you should be thinking about is maybe I should back this off to Q6 or TID or TID and PRN. That, for that patient, that's the best evidence that you have collected at that time. Again, going to the next room, that doesn't mean that patient will respond the same way. You would change their care plan. So that's a single observational study. Now, how do we get to a better confidence? And I use the word confidence, that I have confidence in the intervention. Let's say breathing treatment. Let's say we have a nebulizer we're using called nebulizer A, and we're going to try nebulizer B. How might we determine whether one is better than the other? Well, in some cases, it might be the same. Here's one way to do it. Patient we just talked about on Monday gets Neb A, Tuesday Neb B, goes back to Neb A on Wednesday, Neb B on Thursday, Neb A on Friday. If I did that right, you would get that data and you might be able to see a difference for that patient for that particular intervention. That's good for that patient. I would say, nebulizer B provided better breath sounds. They had coughed out their secretions and their pulse ox was better. That works for that patient, but it doesn't mean, again, go in the next room, that the next patient will respond that way. So what if you took that same study and you did it with 100 patients or 50 patients or 25? Well, it'd take you a long time. But what if you called up a couple of your buds and said, hey, would you be interested in doing a simple study? Very inexpensive. We got Neb A, Neb B, and we alternate days. We collect all the same data. We assess the patient in the same way. So at the end of, let's say, 6 months, you have 1,000 of these interventions, and it shows clearly that nebulizer B is superior to nebulizer A. That's science. That's the highest level of evidence that we have. Now, going to the top, N of 1 randomized controlled trial. I didn't describe that. What I just described, what I call, is a A-B comparison. A meta-analysis says, well, they did it, they did it, they did it, they did it. Look at all these studies. I have confidence that the outcome, that is the superiority of nebulizer B, is established because we had 1,000 data points, not just one patient in your hospital. But N of 1 says that we have a known intervention. I'm going to use mechanical ventilation for this. We have a known intervention that time has told us, experience has told us, observations have shown us, helps people breathe. So here's your study. You're going to, for individuals coming in the emergency room, the first individual, this is an A-B comparison, isn't breathing. You place them on a ventilator and the ventilator breathes for them and they survive. Next patient comes in the emergency room, they're not breathing, and you say, nope, you're not going to get a ventilator. We would not do that. So when someone challenges us, why are not our services, our procedures, all validated at the highest level? Very little of medicine is, because it would be unethical to withhold known care, in this case, life-saving care. Let's go back to 1996. Dr. Jamie Stoller, Cleveland Clinic, and his team said, here's evidence. We implemented respiratory therapy consult service. That's the RTCS, excuse me, for simple water. And what happened? Patients got the therapy that they needed and costs were saved. Pardon me again. Costs were saved because we didn't do excessive care. We didn't do services that weren't required. Now, Dr. Stoller was a part of this group with another physician as the lead investigator and said, we've got a wealth of evidence that protocols work, but they're almost all in the acute care hospital. We need more research outside the hospital. And I would challenge us to think about that. LTAC, skilled nursing, home care, even telehealth. We need to look at the value of patient-focused protocols. Now, here's a study published in Pulmonary Therapy about 5 years ago, I guess now. Geez, 5 years ago. And they looked at, does it make a difference if an individual, a patient, an inpatient individual is ordered for the aerobic OPEP device? There were no studies done at this point. And what did they do? They had a third-party data analytics firm look at hundreds and hundreds of medical records, and what they found is those individuals who were ordered and utilized the aerobic OPEP device were far better. In fact, if you average all these improvements, somewhere around 25 to 28% reduction in exacerbations, and per patient cost was 34% lower. Why do I keep saying cost? Because the first two are safety and quality and cost. When you're meeting with individuals, okay, I mute myself. That was a big call. When you're meeting with individuals in your organization, you want to think of safety and quality and outcomes and patient satisfaction and cost. So don't forget, we do have to address those domains. Now here's a randomized controlled trial, an RCT, that highest level that I mentioned before. And this is Dr. Coliff group said, does it make a difference when RNs and RTs work together to liberate a patient? I won't go through all the numbers. The data shows absolutely. The median time on the ventilator was reduced from 44 hours to 35 hours. So you're thinking 9 hours, what does that matter? That's 9 hours that the patient you're caring for doesn't have a tube in their throat. That's 9 hours that allows that individual to not only be liberated from the ventilator, but helps direct them toward a path of being discharged from the ICU. And there was no difference in mortality rates, which is important when you're talking with compliance and legal and others. Now, this was an abstract published in Respiratory Care 1 year ago. And this group, Matt Pavlichko and his team at Lancaster General Hospital, Lancaster, PA, took a value efficiency rubric based upon an article that Rob Chatburn, Rick Ford, and I published in Respiratory Care. And they said, this was obviously during COVID, but we've known for time that some of the procedures that we do are not validated, meaning not clinically validated at all, plus others are not being adjusted as the patient improves, what I call Q4 out the door. So this team assessed patients and they found 8.6 FTEs of respiratory therapy time. That is somewhere north of 19,000 hours, maybe 20,000 hours, and do the math real quickly. 20,000 hours thereabouts are not valued. They didn't cut them. They cut them and pasted them into other roles, in particular, critical care, so they can provide services such as mobility program. So when you hear services are overutilized, we need to cut those RTs. Think about cutting waste, pasting into value. This study published in 2013 by the Advisory Board Company. The Advisory Board Company is one of the most respected, if not the most respected, organizations that look at quality and safety and outcomes. And what they published this article on work done at Tidelands Health Acute Care Hospital. And the situation they had, physicians were reluctant to change based upon the nebulizer they'd used forever and a day. They liked it, it's custom. They got a multidisciplinary team, and I want to underscore multidisciplinary team, physician, nurse, respiratory therapist, and others, and they educated, selected a new device, and that device saved money. That device saved over $90,000 based upon reducing length of stay, over $74,000 for utilization for the diagnoses listed. So when someone says, hey, I can find you a less expensive neb, or even use the term, I can sell you a cheaper neb, ask, does it provide the outcomes? Saving 50 cents or $1 up front versus spending that money with a nebulizer that gives you better outcomes could save a lot more. Saving $1 in a neb is never going to save you $140,000, $50,000, $60,000. This is an interesting study recently published, and what they looked at is, are there any individuals that undergo surgery that have negative outcomes, in this case, post-op pulmonary complications, and how would we know it? So what they did in the study, they screened 535 asymptomatic individuals. 11.4% had some sort of airflow reduction. And in those individuals, they had a higher rate because it was undiagnosed. We didn't know it. These patients were at a higher risk for ICU admissions and 90-day, and underlying 90-day hospital readmissions. So what this says to me, and I'd appreciate your take on this, is that we need to have some sort of rubric or algorithm to assess individuals who are deemed to be higher risk for post-op pulmonary complications, and others as well, deep vein thrombosis and others outside of our bailiwick. As we spend time identify them, then we can provide care to prevent post-op pulmonary complications. Now, I mentioned about third or fourth slide that one study showed that implementing patient-focused respiratory care protocols improved staff satisfaction. It actually did more than that. It improved staff satisfaction, reduced turnover intention, and reduced job stress. This was published about 7 years ago, exactly 7 years ago, and certainly pre-pandemic. Were there issues of satisfaction, turnover intention, and job stress then? Absolutely. Always has been, always will be. Pandemics certainly highlighted that, but the stress and dissatisfaction has been in our profession, and I would suggest nurses, physicians, and many others forever and a day. We're just talking about it more during this highest point of stress with the pandemic. So implementing protocols, good for the patient, good for the budget, good for respiratory therapist, good for the system. This is a study published about almost 2 years ago in respiratory care. It's called the Risotto study. And when I read the study, I was infuriated because not with the researchers, they're good people. What this study showed is that they asked respondents, who does the assessment for home oxygen in your organization? And if you add up every time there's a respiratory therapist or an RT listed there, it's less than 27, 28%. Why is it when the only healthcare clinician who is educated and competency tested to deliver respiratory care is only doing it 1/3 of the time? I bet you know all the reasons, and obviously pandemic, you're stretched and have vacancies and use agency staff, I get it. But if we don't use our best resource, to assess the patient, are patients going home on the wrong amount of oxygen? Absolutely, studies have shown that. Are they being checked after discharge to see if they still need maybe a month out what they have when they left the hospital? We need to be the ones to do that. That's our role. That's our value proposition. This is a study done. Actually, I got to be friends with a fellow who did this study, John Wilson. And I was living in Pennsylvania at the time, and interestingly moved to North Carolina. And his hospital is one mile from the hospital that I used to work at. And I remember reading this, and I talked with John and another fellow who presented this at the Congress. They switched from their current nebulizer, whatever it was, to the breath-actuated nebulizer, the AARC-approved CEU nebulizer. And what did they get? 20% reduction in total cost, 31% decrease in the time, 21% increase the time between treatments. So how did that happen? Fewer treatments, less PRN calls, more therapist time. Who wouldn't want that? All because they looked at the literature, put a team together, tested it in their organization in their 38-bed pulmonary unit, and showed that this band nebulizer, pardon me again, produced these outcomes. Now think about that. Who would be interested in reducing cost? Everyone would. Who would like to have more time in the day? Everyone would. Who would like to have greater time between treatments? Mostly the patient. If you have an effective treatment, you need to deliver less, and maybe giving them that last treatment in your Q4 while awake or QID program. Maybe they don't have to wake up during the middle of the night because they had an effective treatment. Now, this is actually a response to a study done in my area with my former medical director and Dr. Qi Lo, who now practices in China. And they took their COPD pathway And as part of that, they started to test individuals to see what their peak negative inspiratory flow rate was. And what they discovered is a significant number of individuals had a peak expiratory flow rate, meaning negative, less than 40 to 45. As you know, and they discovered, if you don't have that for certain of the dry powder inhalers, you cannot get effectively utilize that device, and you won't get the benefit of the medication, which have been a lot of money. Great medications as they are, but if the patient can't inspire it because they don't have enough inspiratory flow rate, they need to be put on an effective nebulizer and compressor combination. Does COPD work? Absolutely. Here's 558 patients, and each patient was studied the year before their ED use and their hospital admissions, and the year after pulmonary rehab. So here's a very simple methodology that you can use to test an intervention. Every individual serves as their own control. So they looked at all these individuals, 558, and here's where the outcomes. They could walk farther in 6 minutes. Their SGRQ improved by about 10 points. Those are important, but aren't seen to be long-term outcomes by finance and budget and others. Third bullet point's interesting because what if you're keeping these folks out of the hospital? Good thing. Individuals want to stay in their home. But what if they're using the emergency department more? Well, it didn't happen. It didn't change. The last two bullet points are golden. Admissions were reduced 20% for an entire year after the program. Patients who declined pulmonary rehab for logistical reasons, and this is a topic in another lecture, maybe I'll be able to deliver in the future, called the impact of social determinants of health on health. Less than 10% of the health of a population has anything to do with medicine. 80% are the social determinants of health and other logistical issues. For those individuals that did not, for whatever reason, enter and successfully complete the program, they had a 40% higher risk of hospitalization, and that is significant. Now, we've been focusing on COPD and pneumonia because they're in the PPAC readmission penalty program, but what about asthma? Kids with asthma, and I stopped calling them asthmatic kids, thanks to Dr. Bowman, who educated me. They're a kid first, they happen to have asthma. Let's call them kids with asthma, or adults with asthma. In this case, they had 55 individuals who had been admitted to the PICU and had either 2 or more hospitalizations or ED or urgent care visits in the past year. They put together a team. They educated the patient face-to-face of their medications, their asthma plan, their zone tool, how to utilize their medication, make sure they could take them. And they also made sure that they got with a pulmonary or allergist. Look what they got. Prior to this, every single individual had been in the hospital or ED or urgent care. After they started this program, completed the program, it dropped from 100% to 38%. That shows the value of a team, one member of which is a respiratory therapist. Well, I mentioned earlier about ventilated patient mobility. Does it work? Absolutely. A number of studies done by Pete Morris and his team, 2008, repeated 2012. And this study published in the Archives of Physical Medication and Rehabilitation about 5 years ago said, absolutely. Mobilizing patients does a number of things. Ventilator comes out quicker, tube comes out quicker, they get out of the ICU quicker, and costs are lower. When I talked live with folks, I did a couple of weeks ago, I said, how many individuals, about 180 people in the room, how many individuals routinely, and I mean regularly, routinely in a scheduled basis, mobilize their ventilated patients? 3, 4, 5 hands went up. 180. This is science. This is where we need to be showing the value of the respiratory therapist. With, I might add, the RN, because it's not just about the therapist, it's about our collaboration with nursing and ICU. The question had been, until this article was published 2017, we know that physicians, extenders, pharmacists, and others have been disease state managers, to use that term, and have had positive outcomes. At least I was not aware until this article published by Patty Silver and Maren Colifan team in 2017, when they assigned a respiratory therapist to manage our part of a disease management program, what were the results? And look at them. Decreased readmissions, 28 to 20%, decreased the median hospital stay, 8 to 5 days. That's significant savings. Total inpatient days dropped over 200, and ICU days dropped from 53 to 17. Better safety, better quality, better satisfaction, engagement of patients and families and others, better satisfaction of respiratory therapists, and save money. What's not to do? We need to make sure we have the time, the ability to do this. Here's a real-world study, and what these folks looked at is what is the standard for COPD care. In this case, they utilized the aerobic OPEP device. The patients ordered for that. Did it make a difference? And at 30 days, absolutely. Significant reduction in exacerbation for the COPD patient. If a COPD patient in their home or wherever level of care they're at has significant reduction in exacerbations, you have to ask the question, does that mean they won't be coming back to the hospital as much? The answer in my world is absolutely. And they also had a significant lower cost. Safety, quality, patient family satisfaction, and cost. It checks all the boxes. Just earlier this year, this article was published, which I had not seen this level of scientific inquiry for the therapist in the home to this level. What did they do? They put a respiratory therapist in the home. They had almost 1,100 participants divided into the pre-intervention group and 435 in the post-intervention group. Look what happened when a respiratory therapist helped patients in their home. Readmissions in 30 days dropped significantly, even bigger drop after 60 days, even a greater percent drop from 43 to 13%. That's more than a 2/3. I probably almost 70%, I guess, drop. Merely because, only because, just because the respiratory therapist was caring for patients in their home where they want to stay as an individual, not a patient in our hospital. So let's summarize this. What's the first step? My advice, my recommendation, get with your RT medical director, get her on board. Make sure that she understands the science that's available. Every physician, smart, obviously, they graduated medical school, they did internship, residency, fellowship. They understand medicine like you and I will never have. We don't have that depth and breadth. But in respiratory care services, we've got the depth of knowledge. We need to make sure that we're on board with our medical director. Secondly, get a team together, not just therapists. Yep, we know our stuff, but what about pharmacy, nursing, performance improvement, quality assurance, finance, budget, chief medical officer, chief nursing officer? Think about all those individuals that you could assemble as this project lead, or maybe your department head is a project leader and your staff therapist on this team. Think beyond the badges. Think beyond RT. We're stronger in numbers. We have better depth and breadth of knowledge. Develop the plan. Test it. Do the research. Make sure we're using the highest level of available evidence. Everything's not at the end of one randomized controlled trial. Will never be. Utilize the best available evidence. Educate. RTs, administrators, all your stakeholders before you launch it. Pilot it. My opinion is pilot in one unit, get it right, test it, communicate. Utilize this if the outcomes are what you wanted, positive patient outcomes, let the world know. Let the world know that the team achieved that, not the RT, the team achieved that. We're at the table, we may be at the head of that table, but my strong recommendation is think team, not think individual. Last is PDSA. You may have implemented a protocol that didn't provide the outcomes that you're expecting. Why not? Maybe there was something that didn't work. Go back and fix it and do it again. Let's say you achieve the outcomes. You say, well, we're not satisfied. We learned that we could do something better, something new, something innovative. Go back, add that, start at the top, work your way down, look at the outcomes, communicate them, and PDSA. Don't ever be satisfied, and I'm sure you're not. Don't ever be satisfied with what you got first time out. That's why we have continuous quality improvement. We are always looking to be safer in our delivery of care. And that's why we will demonstrate, communicate the value of respiratory therapists. And with that, I will thank you for being a respiratory therapist. My alarm says we're right at the top of the hour at 2 o'clock. So I'm going to bring my face back. I'm going to stop.